Dear Professor Kim, dear Professor Ko, dear friends, it's a great honor for me to be here today to present you the view on the improvements of TORS during the last 10 years. I have nothing to disclose, but I would like to congratulate Professor Choi, Professor Kim, and Professor Ko for these 10 years of organizing the International Robotic Surgery Symposium here at EMC. It's really one of the best meetings that we have in the field in the world, and it's why people come from every part of the world to share their experience and learn with you here. Thank you very, very much for all this work you have done. Before the era of TORS, the surgical options were pharyngotomies with mandibulotomies or even mandibulectomies. These were very efficient procedures, but associated with considerable morbidity. At the same time, clinical trials were showing improvements in survival with the use of targeted therapy or chemotherapy associated with radiotherapy. The results of the trials, however, were not reproduced in real world, as you can see in our experience using chemotherapy and radiotherapy for advanced oropharyngeal cancer. As usually, we surgeons do not have clinical trials to show. The results that we publish are usually based on retrospective series like these two ones. The first one, in the left side, showed survival rates better with surgery than with radiation therapy. The second one, in 3 Brazilian institutions, showed survival rates that may be comparable to the published with chemoradiation for advanced oropharyngeal cancer, but it's not level 1 evidence to support surgery as initial treatment for oropharyngeal cancer. For this reason, at that time, we were using surgery or radiotherapy alone for the treatment of initial stage oropharyngeal cancers. Surgery and radiotherapy, or the combination of chemotherapy and radiotherapy, were recommended for patients with more advanced disease. The only situation that we could prefer surgery was the situations when we expected better functional results with surgical treatment. Because of the lack of evidence, NCCN guidelines at that time were more in favor of non-surgical treatments than surgical treatments for any stage of oropharyngeal cancer. At the beginning of this century, numerous evidence had confirmed the role of HPV as a risk factor for oropharyngeal cancer. But only in the year 2010, Qianang clearly demonstrated that HPV tumors were associated with better survival rates. For this reason, in many institutions around the world, chemoradiation became the standard of care for patients with HPV-positive oropharyngeal cancer. However, real-world experience showed that HPV-positive tumors were also associated with better survival outcomes even in patients who underwent surgery as first treatment. So there is no difference in survival according to the treatment modality in HPV-positive tumors. In spite of good response rates and survival rates, chemoradiotherapy was associated with significant morbidity. Meantime, a revolution was in preparation. In the year 2000, the Vinci robot was approved for the use in general surgery. 3 years later, a porcine model of robotic neck surgery was demonstrated. 3 years later, a cadaveric model showed the possibility of using transoral robotic surgery. Then, in the year 2010, the first human trial was published. Weinstein and Bertolmale published a series of 47 patients with advanced oropharyngeal carcinomas who underwent TORS, neck dissection, and adjuvant treatment if necessary. There was no intraoperative or postoperative mortality. Margins were positive in just one patient, and there was just one local recurrence. Disease-specific survival was of 98% at 1 year and 90% at 2 years. 18 or 38% of the patients avoided chemotherapy, and 11% did not receive radiotherapy or concurrent chemoradiotherapy. In the same year, a multi-institutional series with almost 200 patients confirmed the safety of TORS as the initial treatment for oropharyngeal cancer patients. The authors didn't report any mortality among the operated cases. This early evidence supported the replacement of open surgery by TORS. And in 10 years, hundreds of trained surgeons had performed thousands of TORs in different countries of the 5 continents of the world. So, the initial indications for TORs were primary resection of squamous cell carcinoma of the tonsillar fossa. Just for T1, T2, and some selected T3 and T4A tumors. With growing experience, it became clear that several factors can be contraindications for surgery, and some are specific contraindications for TORs. Some general contraindications are patient-related, such as advanced age, coagulopathies, and severe comorbidities. Some anatomical limitations for TORs are patients with trismus or macroglossia. And there are several tumor factors that are contraindications for surgery, like involvement of the carotid, involvement of the base of the skull. But mandibular invasion, for example, is a specific contraindication for TORs. The root of tongue invasion is a contraindication for TORs. And the tumors that invade the base of the tongue and cross midline are also considered or were considered contraindications for TORs in the past. Previous treatment was considered a contraindication for TORs initially, but this article published in the year 2013 showed that patients who underwent salvage TORs had less surgical time, had less loss of blood, and they needed less tracheostomy and PEG. Patients who underwent salvage TORs had less complications. Their hospital stay was lower, and they have improved survival results as compared to open surgery. It became very clear that the more experienced surgeon had less complication rates than the beginners. To summarize, the current indications for TORs are primary or salvage resection for resectable squamous cell carcinoma of the tonsillar fossa. These tumors must be T1, T2, and some selected T3 or T4A. It is necessary to have good exposure in an operable patient, and the procedure should be performed by an experienced surgeon. Let's move now to the topic of improvements of TORs. To improve a surgical procedure, it is necessary to consider the reduction of the risk of complications, especially the life-threatening complications. And the most important complication in TORs is bleeding after the operation. That in this series, it was shown that it was present in 5.4% of the cases. 2/3 of the patients needed reoperation, and it was really severe in 1.1% of the cases. Because of this, several surgeons proposed a modification in the strategy of performing TORs and neck dissection. For them, it would be safer to perform a neck dissection 2 weeks before TORS, and in this procedure to promote the ligation of the branch of the external carotid artery. In this study, glycine reviewed 201 patients who underwent TORS. Most patients had no prophylactic ligation of the vessels, but 52 patients had prophylactic ligation. The rates of bleeding were the same or very similar in both groups, but severe bleeding was registered only in patients who were not submitted to prophylactic ligation of the external carotid branches. Another significant problem for patients who underwent TORS is airway control. At the beginning of the experience with this operation, about 30% of the patients needed prolonged intubation, or about 15% of them were submitted to a tracheostomy. With more experience, it was shown that most patients could be extubated before 6 hours. Just 3% of the patients needed a perioperative tracheostomy, and less than 1% of patients needed an emergency tracheostomy. So, this reduction in airway complications is a remarkable achievement in TORS surgery. Another improvement was the use of a retroauricular approach for neck dissection. It's a safe procedure. It's not just a cosmetic procedure, but it reduces the risk of vascular complications of neck dissection. This case is an example of the standard that we are using especially for young patients. Just after diagnosis and stage, we perform the neck dissection through a retroauricular approach. You can see in the middle the patient just 3 days after surgery, and then 2 weeks after neck dissection we perform TORS, and you can see in the right side the patient 3 months ago, the last procedure. Another significant contribution from the Yonsei group was the use of neoadjuvant chemotherapy for patients who have advanced disease that they are borderline for the indication of TORS. Other contributions came from clinical trials. 2 days ago, I accessed clinicaltrials.gov, and it was possible to identify 22 trials on oropharynx cancer and TORS. 7 were terminated or completed. The Orator trial was published last year, and it compared swallowing function after TORS or radiotherapy for early-stage disease. The trial showed superior swallowing-related quality of life score in patients who underwent radiotherapy. In this trial, there was no survival difference between the two groups of patients treated. Also last year, Chris Singer and co-authors showed that the new generation single portal Da Vinci was feasible, safe, and effective for transoral robotic surgery of oropharyngeal cancer patients. The Avoid trial, published this year, included patients who underwent TORS, had clear margins, and no pathologic factors that would be indication for postoperative radiotherapy, except for pathological positive lymph nodes in the neck. In these patients, the intensified postoperative radiotherapy that avoids the resected primary tumor and targets only the at-risk neck after TORS for selected patients with HPV-related oropharyngeal squamous cell carcinoma may be safe. So, the primary tumor site could be not irradiated, reducing the morbidity of the operation and adjuvant therapy. This very significant publication from John de Almeida analyzed more than 400 patients who underwent TORS for oropharyngeal cancers. Almost 50% of the patients didn't receive adjuvant treatment. In a median follow-up of 20 months, local recurrences were reported in just 4.5% of the patients, and the 2-year survival rate was of 91%, proving the safety of TORS in well-indicated cases. This is another study published in the year 2017 using National Cancer Database. They reviewed more than 22,000 patients with advanced stage oropharyngeal cancer patients. Most patients underwent chemoradiotherapy, but the survival results of patients who underwent surgery and adjuvant treatment was superior to the results of chemoradiation. The 3-year overall survival was 85% in the surgically treated patients against 72% of the patients who were treated with non-surgical treatment. A very, very significant difference in favor of surgery. Now we know that surgery is better than chemoradiation, but in surgically treated patients, especially in early-stage disease, is TORS better than conventional surgery? In this study that was published this year, using National Cancer Database, they analyzed almost 10,000 patients with T1T2 disease, of whom 2,600 underwent TORS. Patients who were submitted to TORS had less positive surgical margins, and they used less frequently adjuvant treatment. In a subgroup analysis of 4,000 patients with non-HPV status, TORS was associated with improved overall survival compared to non-robotic surgery in multivariate Cox proportional hazard regression. The authors concluded that this study suggests that transoral robotic surgery was associated with improved surgical outcomes and survival compared to non-robotic surgery in patients with early-stage oropharyngeal cancer, and this is the best evidence that we have today. Survival is better with TORS, but we didn't prove yet that we can achieve better quality of life using TORS in patients with early-stage oropharyngeal cancer. But on the other side, de Almeida showed that TORS is cost-effective for the treatment of early-stage oropharyngeal cancer. That concludes my lecture. However, I would like to quickly summarize the main points. The first one, TORS can be indicated as a primary or as a salvage procedure. TORS is safer than open pharyngectomy. The most frequent complications are bleeding and dysphagia. The rates of complications can be reduced with experience. Timing of neck dissection and arterial ligation do not prevent bleeding, but reduce its severity. Patients who are candidates for TORS can achieve similar or even higher overall survival rates, and another benefit, they can use less adjuvant therapy, reducing the sequelae of the treatment. And finally, TORS is cost-effective for the treatment of early-stage oropharynx cancer. I sincerely appreciate that I have had this opportunity to present the lecture on the 10th anniversary of IRSS. Thanks, Professor Choi. Thanks, Professor Kim. Thanks, Professor Ko. Thank you all very much for your interest and kind attention.